what's a pharmacist got to do with continuous glucose monitors? How does that fit in? Because the idea of a pharmacist, and we're thinking about a pharmacist when people walks into a pharmacy. Now that's different to your job role, but when people walks into a pharmacy, the pharmacist, typically the journey for the patient is, here's my prescription, please can I have my medicine. Yes, pharmacists can do more than that, so they might get advice on certain minor ailments as well. So there's a lot of different things they can do, and people pop into pharmacies for more than their medicines as well. But typically we associate pharmacy with pharma treatments, so drug treatments. How then does the narrative of a pharmacist fit into why you got excited about CGMs back when you were working in the NHS?
Yes, so as you said, we support prescribing, we dispense as well. And one of the things that people would know this anyway, when it comes to getting your blood glucose testing strips, you go to the pharmacy and it's issued for you. Now, as a medicines management pharmacist, we were given drug budgets to manage. And within the drug budgets, we call them drug budgets, but we also have devices in them as well. So those are the blood glucose testing strips as well. So when these continuous glucose monitors came out, that was added to our drugs budgets as well. So, we had to manage that as well. So, that's where we got involved. And then
Just for people to really understand this,
Mhm.
what is a drugs budget, and why is that important? And I guess what I would find interesting is a drugs budget about where to allocate the budget, or is it about saving money? What is important about this drug budget?
Okay, so when it comes to prescribing, each GP practice is assigned a budget to spend on medication. Now, they're not handed over the money. We keep it within the organization, but it is a finite amount of money, and medicines management pharmacists are involved in making sure that the GPs stay within that budget so that they don't overspend. Now, if they do overspend, that means there'll be less money available for hip replacements, for nurses, for all sorts of other services within the NHS, because the NHS doesn't have an infinite purse. So that's why it's very important that we make sure that GPs don't overspend, and we put in.
This is super interesting.
Yeah.
This is really super interesting. And I think it's a really nice insight for people that we're not always trying to prescribe the medicines for you. We're actually sometimes trying to make the best of all the different choices that are available in the NHS,
Yes.
and actually prescribe it economically
Mhm.
as well, because we've got to think about the wider population health
Yeah.
perspective and the trade-offs between
Yes,
different things.
absolutely.
And your role as a pharmacist isn't actually about prescribing. It's about, in a way, it's about a mild form of policing this, isn't it?
Yes, 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 yes. A lot of the time, that's what the GPs refer to us as,
Yeah.
the medicines police.
Well, I can tell you a story about that, because I was like, okay, this Ozempic stuff is really going to help my patients. Licensed for type 2 diabetes, not allowed to prescribe it in primary care. And then in April 2024, or maybe it was slightly earlier, I was like, right, I'm prescribing it. This patient needs it, clinically needs it. So I prescribed it at around 11 a.m. At around 3 p.m., I get an email from the GP partner at the practice, and she says, did you prescribe Ozempic for this patient? I said, yes, clinically appropriate. And she says, well, I've had an email from the powers that be, i.e. medicines management, pharmacy, which cover, all electronically connected. And they have said that you did this and you can't do this. So I just got like a big slap on the wrist and say, we're now in trouble because you did this. So Big Brother is watching, and Big Brother might be Efa on the other side, or your replacement, essentially.
Yeah, it happens. The thing is, there's nothing much we can do, but it just puts a lot of stress on the system. And then you might hear that some of these organizations are very, very overspent, and these little things all add up to making the organization overspent. And then, they go under, Big Brother from the NHS England comes, and they're monitoring us, and
They're monitoring you.
yeah,
It's all connected.
yeah, it's all.
It is hard from an autonomous perspective as trying to do best for the patient, but ultimately, I can understand in the NHS this is a whole systems view of
Absolutely.
health overall. So I guess people can probably take from that there's a whole interconnected
Yeah.
web. So when someone is saying they're not doing something for you,
Yeah.
often it's because they can't, because the system itself needs to function within this as well.
Yeah, yeah. It's very, very difficult for the GPs as well,
Mm,
to pass that message on to the patients. And sometimes the GPs
yeah.
used to get the patients to call us so that we can explain to
Yes.
them why they can't
Yeah.
prescribe certain things.
Yeah, sometimes
Yes.
sometimes we're getting a headache from patients. Sometimes
Mhm.
you give us a hard time, so we pass on that hard time and we pass it on to medicines management. And actually, what it does is it creates a little emotional barrier, doesn't it? It
Yes.
says,
Yeah.
well, what we say is what what we do with our patients is we say, well, we would like to make the decision and support you, but unfortunately, someone else is the devil that's saying no. So we're going to pass on the devil responsibility, and we're going to say medicines management have to deal with it.
Yeah.
And then medicines management can say, well, we would love to prescribe it to you, but actually NHS England says no.
Yeah.
So write a letter to your MP.
Yeah.
And that's then what happens. So obviously not great for people, but often that's
Yeah.
the pathway that
Yeah. That's
happens.
what happened.
So you talk about the drug budget then. So you mentioned around the glucose testing strips they were costing, and then you're thinking about bringing in the continuous glucose monitors
Mhm.
as a way to potentially save money in the budget.
Yes, absolutely. So, well, so when we started using it in patients with type 1, we've noticed that their control of their diabetes improved. So we started collecting evidence that this was helping patients improve their diabetes. And how do we know that their diabetes has been improved? We use what we call an HbA1c test, and that measures the average blood glucose over 2 to 3 months. And as this number, the lower the number, the more controlled is your diabetes. So, with
Mm.
time, as we started rolling it out, we realized that patients who use this device, the CGM, their diabetes control was getting better. So
Were we getting feedback as to why it was helping for type ones? Like, what was the on the ground feedback from
on the
patients?
ground feedback is patients can see when, like with type 1 is slightly different, but they can see as when their blood sugars are going low and help prevent what we call a hypoglycemic event. So
Mm,
whilst they can see it's coming down, they can quickly respond and
mm,
alleviate that problem. So alleviate that problem. Sorry, and if it's going high as well, they can see it quickly and inject more insulin. So it was preventing
mm,
them from having severe hypos and
mm,
hyperglycemia, preventing them from calling out ambulances. So therefore, their blood sugar was better controlled.
mm. It's interesting how or why what the incentive was, and maybe it's slightly perverse in thinking about this, but the NHS has to have a strong incentive to introduce a product. And incentives normally lie around how do we make things more efficient, and efficiency often comes out as cost savings, or it's that's how the narrative goes. And when you can prove an economic basis of cost savings, then a new product can come into the market. And so for me, in my pessimistic viewpoint of how we want to improve patient care, I wonder whether a lot of this push was not because of the quality of the A1C control, the overall diabetes control, but a big drive would have been about the risks of having the hypos and the associated costs within the health service. Now, I'm going to outwardly talk about this, and it'll be really interesting for people to provide different opinions on this. But what are we doing in healthcare here? Are we trying to reduce the cost in the system and then by accident improve patient care? Or are we actually trying to directly improve patient care? And I think for me, there's a bit of frustration there, but you might be able to provide insight on that. And maybe I'm being a conspiracy theorist, suggest that it's about the hypos. What are your thoughts on that?
I think it's a mixture. I think within the NHS, we all have good hearts. We all want patients to do well. But we also have this budget and financial constraint. A lot of the time, implementing these new technologies requires a cash investment to support them, because the benefits are long term and we only see the benefits in the future. So we need
Mm,
to, we need to have a longer term view for what we're doing. But then,
mm,
with the pressures that are on the NHS about saving, this is your budget for the year, and within that year, we need to make savings. It's very
mm.
difficult to find that extra money to
Yeah.
invest for the future. So, this is where it's all tied up. But everybody really, really has the patient's interest at heart. But because of the
Mm,
pressures from above, to spend within a budget and finding the extra cash to implement these new technologies for that
mm.
moment in time becomes a big problem.
I think there is this thing about pressures, and I think the incentives are not sometimes so clear. And I'm just now thinking with my MBA hat on and thinking about large corporates and how they struggle to innovate and introduce new products sometimes compared to smaller startups. And what they've done, many of them have created a separate arm which isn't touched by the rest of the corporate, might even have a different name or under a name where people won't even know it's associated with that corporate brand. And they will be essentially become a think tank or being given a small amount of funding to introduce something and test it, but also with no repercussion if it fails, as long as obviously it's safe. And I just think the NHS is trying to do that. I can see that, but it's not being given the full go ahead in certain areas to say, here's your pot of money, have a go with this. We think this is a really high chance that this is going to be of impact. But that comes on to what you did, because actually you did in a way manage to get some funding and do a study and actually show impact in this in continuous glucose monitors, didn't you?
Yeah, yeah. I must say, it wasn't easy, getting it
Yeah.
approved. It was really, really difficult. And there was all sorts of things that went on before it did get approved. I worked with only 100 patients across North Central London. And, it wasn't very expensive. And I think
Mm,
that's why it did, get approved. We just got a little bit of money to try and sort it out. And then also, it took about at least 3 years to get the
yeah.
whole thing done.
These things take time. And do you know, you say not very many, but to get 100 people looking at their monitors and seeing impact is really huge. And I think maybe in the NHS we get used to these big numbers, but outside the NHS, to manage to get 100 people together and to study them like this is really, really difficult. So I think even in that sense, it's no easy thing that you've done. But before we talk about the study, because the study is really, really amazing, I really want to talk about it.
Okay.
What was the thing that got you switching from like, okay, this is working from type ones. This is what was the creation? So for people listening, what was the creation of the hypothesis, the idea that this is going to have an impact, which would then lead to the funding?
Okay, so what happened was, Abbott, who came out with the first CGM in the country, they had a website where people could, if you had diabetes, you could just apply, and they'll give you one free sample to try it out. So once that started, everybody was going for it. Even I went and I tried one as well, but I got people I knew who were close to me to apply for it. And and they had type 2 diabetes, once they wore it and they had that immediate feedback, they were like, whoa, this is so much. The people I worked with was someone who used to fix my windows for me, and he did double glazing, and he had been to several NHS diabetes education sessions. And I'm like, wear this. I got him to order it, come to my house. I put it on him, and he went away. And he lost 3 kilos from just wearing it over
Wow.
14 days. You understand?
Wow. What did he learn? I mean, what did he learn in those
So
14
he
days?
actually said to me that, all this NHS education programs that have been going on hasn't taught me as much as what this device has taught me. And he said he used to have oats and bananas for breakfast, and he realized how high it shot his blood sugar. So he changed that, and then his blood sugars were less. So he
Mm,
wasn't seeing all those spikes. And then he saw that his meal choices were really making his blood sugar go up. And when he stopped
mm,
eating those and he changed his meals, he realized that his blood sugar wouldn't spike so much, wouldn't stay up for so long. And whilst he was just making these food choices, his weight came off. So he wasn't using it for weight loss, but he was using it to rather control his blood sugars and make them more stable. And then he came back and said, this is an amazing device. And he was just blown away with it.
So for people listening, how much did he have to invest now then, and then how much does he have to invest in his health now to
So
keep learning, or does he still use them?
So no, he doesn't use them. He doesn't use them. But at the time, because it was for free, he was very happy to use it. And at some point,
Mm,
he had a problem with it, and he contacted the company, and they sent him another one. And
mm.
it was just that short period of time that educated him about his food choices, and then he changed the way he ate. Yeah,
Yeah, I think that's a really interesting thing. People. One of the narratives that I hear sometimes from the health industry is that if people start using monitors, they're going to need to use these all the time. And so for people know in terms of cost, you can get them roughly around £52, 50, £52 every for one monitor. So for every 2 weeks, it'll cost about £50. So if you were to wear these all the time, it's £100 a month. It sounds a lot, especially if we're not used to paying for healthcare. That's essentially £1,200 a year, which isn't cheap. You don't have to wear them all the time. And no one, not even my clients, I'm sure not even your patients, wear these all the time. But once they wear them once, it's then the learning that's the power.
yeah,
It's not just like being reliant on this. You don't have to keep scanning it or keep looking at it and thinking, okay, this is what my number is. This is a once episodic thing where you might use it again in the future because getting re-insights is helpful. But if you spend, say, 100 or £200 on this in terms of investment in your healthcare, maybe even in the first year, and then you may not even have to spend that much,
yeah.
then your actions change, don't they?
Yes, and then what we don't take into consideration is these are patients who probably would be put on one medication that's about £40 a month, and then another one, and how much does that work out across the
Oh
year?
my gosh. Oh my gosh, we know about costs of medicines. So let's put that in context. So someone's getting a GLP-1, a weight loss medicine
Mhm.
in the NHS. It's costing about is it £99 a month?
Yeah, yeah, that's right.
And then the other medicines which people will be on, including these new ones, some of you will be on them like what are some names? So things like sitagliptin,
Mhm.
linagliptin, which are not that effective, are still costing
Yeah, yeah,
the
yeah,
NHS around £30 a
yeah,
month.
yeah. That's
And then these new ones that many people are on, empagliflozin, dapagliflozin, they're costing around £30 to £40 a month.
yeah,
And
that's
so for the NHS budget, remember, it's not just £30 for 1 month or for 1 year.
right.
It's for essentially
Yeah,
the rest of your
going
life.
forward, not forgetting the blood pressure medications that they would take as well, because
Yeah,
on the pilot that we're going to talk about,
yeah,
some of the patients, even their blood pressure got better, so they didn't need their blood pressure medications
yeah,
as well. And then the other thing
yeah.
that we need to think about is the reduced complications, because their health's
Mm,
better. They're not going to get amputations and all sorts of things
totally.
that are associated with diabetes
So
in the
the
future.
the the expansion of the cost savings and pain savings and discomfort savings is really unbelievable. And just one other thing on the medicines, we have some common medicines like metformin and for some people glycoside. These medicines cost the NHS per month. Is it a couple of pounds? I
Yeah,
don't
yeah,
know. What is
not
it?
not very much, but metformin is quite expensive, because when we look at the drug budgets, like
Yeah,
metformin is one of the top spend in the diabetes area, and that's because we
yeah.
have so many people on it.
We have so many people on it. But the worry is that if more and more people end up on the ones that are 30x cost, the 30 pounds, £40 a month, this drug budget just goes and blows through.
Yeah, absolutely. I had a graph that I put on my project summary that shows the trend, the trajectory of the drug spend for just diabetes only. And it's just going up and up and
It's
up.
just up.
Yeah.
It's huge.
Yeah.
So, okay, now we have to look at the study because we talked about it enough. Now we've got to get into it. This study, I'm going to introduce it and say that this study for me is it's not published yet, is it?
No. It hasn't been
Not
published.
formally
It's just
published.
in a poster format
So
at the moment. Yeah.
this is an unpublished study. You've got the poster format and you've got a written longer form kind of format on it.
Yeah.
And this is powerful. I think it's just simple yet effective. So let's get into it. What was in the study? Tell us about it. So we know there's 100 patients in it.
Yeah. Okay. So we what we did was we got approval from the organisation, and then we put out interest for GPs to apply for. So we got about 8 GPs who applied to participate in the pilot, and they recruited in total 95 patients. We were hoping to get 100, but we weren't able to get 100. And what we did was the entry criteria. So the entry criteria was they should look for patients with whom needed initiation, patients with type 2 diabetes who needed initiation of medication because lifestyle measures didn't help improve their blood sugars. And then also for patients with uncontrolled diabetes with type 2. So those are the people they recruited. We got the GPs trained in medication adjustment as patients got better, and then also on how to use the devices. So at the time, there were 2 devices available. So one was made by Abbott, it was called Freestyle Libre, and the other one was made by Dexcom. It was called Dexcom One. And both these devices, they measure blood glucose continuously. And the patients were given 6 weeks supply of these devices. What else did we do? We gave the patients an information leaflet that explained about the HbA1c, because they would be able to get this reading from the device, and then also it explained about blood food swaps that, and we gave them a visual image of what uncontrolled blood sugar would look like on the graphs that these devices would produce, and what controlled blood sugar would look like on the device. And then
And you compared it to a different group, didn't you? So the group that didn't have the devices. Did you do a
no,
comparison?
we didn't
Okay.
have that. We didn't have enough patients to do.
I guess it would have been, in hindsight, it would have been nice to have a group
Yes.
that didn't have that.
Yeah.
But you do still have the group versus the control, which is what people are continuing to do
Yeah,
generally.
absolutely.
So the rest of the population in that area.
Yes,
And the patients.
absolutely.
So this is really interesting. So I just want people to really get this, because I find this is really powerful. We didn't provide, you didn't provide a training as such. Of course, you tried training in terms of the monitor,
Mhm.
but you didn't provide training in terms of lifestyle intervention.
No.
What you did do is you just did what we already do,
Mhm.
which is give a leaflet out. This
Yes.
is what we recommend you should eat. Perhaps, and maybe you'll just clarify on that, perhaps your information was slightly more detailed, but it's still in a written format.
Yes.
This is the
Yeah.
information.
Yeah.
Then the addition was simply, here's your monitor.
Yeah.
Is that the
Yeah,
simple
that's
addition?
right. And then the visual pictures of what good control would look like and what poor
Okay.
control would look like.
So it's pictures of the graphs.
Yes, the graph.
Okay, that's really helpful. So then we gave them a little bit more educational material,
Mhm.
but essentially what you did was you onboarded them with a bit of support,
Mhm.
and then you left them for 6 weeks.
Yeah, so the first thing we would give them, they came into the practice and they were fitted with the device, and then after about a week or 2 weeks they came back, and if they had gotten on with it, then they were fitted with the device again and given the devices to take home and continue. So that's how it was done. So prior to them starting, we took their HbA1c, which is the measure of control of their blood of their diabetes, and we took their weights and their blood pressure as well. And they wore the devices for 6 weeks, and then they came back at 8 to 12 weeks, where weights were done again, the HbA1c was done again, and the blood pressure was taken as well. So we had a baseline reading and 8 to 12 weeks after they had worn the device.
So pretty standard metrics. So easy to measure this. So
Yes,
pre and
yes,
post.
yes,
Okay.
yes.
And what happened on the results when you rechecked?
So when we checked the results, so the average HbA1c when they started was around 70, which is quite high because you are diagnosed with diabetes when it's above 48. Yeah. So when they started, it was at 70. And when they came back, it was at 60.6. Now, this was for, we
In a space of 2 to 3
no,
months.
yes, exactly. That's right. So
Okay.
it had dropped. And, for some of the patients, it had dropped quite dramatically. And then also, we only got about like 70 results back from the total, which is a good, collecting it back, because some, patients couldn't be
It's hard to follow
contacted
up.
and,
People
all
fall
sorts
off.
of
And, yeah.
things. But the average drop, when we worked out the average for the whole group that we got back, including those who didn't perform well, was 9.8 millimoles per mole, which is really, really like incredible.
It's really amazing.
Yes, that's really, really amazing, because when patients start medication over those 2 months, it doesn't drop it that much.
Yeah, so let's put that in context. So,
Mhm.
let's say, for example, the typical patient that might have been on this study would have been someone who was on metformin and was maybe on two medicines and were thinking about a third medicine.
Absolutely, yeah.
And that medicine, let's call it dapagliflozin or empagliflozin.
Mhm.
What would have been the essential change anecdotally if we were to look at a patient going onto one of those medicines, assuming that nothing else
So when
changes?
I looked at the studies, it said the HbA1c would drop about 0.14% or something like that. I can't remember.
Yeah.
It was very, very little.
So
Very, very.
0.14, so it's 0.12. So probably a couple of millimoles per mole. So in terms of the units that we're using, instead of a 9.6 drop, we're looking at an estimated drop of around 2.
Mhm.
But I would say anecdotally, I would see probably if someone's at around 70, because obviously it depends on where you're at in scale as well in terms of the impact. I would say perhaps this is probably about a 4 to 5 drop. So we're still looking, if we're looking from a very positive aspect of the medicines, a double drop
Yeah, yeah,
compared to.
absolutely. Yeah.
And for that person, of course, there was a high cost intervention because it was a study and because it required someone to support them at the start and at the end. But if that person had bought their own monitor and had access to education materials, it would have essentially cost them around £100-150.
Yeah,
So same cost
yeah,
as, or slightly, but if we include the GP appointment, etc., for prescribing, let's call it on par. But the long term
yeah,
impact
yeah,
now is what's really exciting
yes.
because they now know this information. It doesn't go from them, does it?
Mhm, mhm. Yeah,
That's what
absolutely.
I find really
So,
fascinating.
yeah, so that education. So we do educate patients when they're newly diagnosed with diabetes. They online or wherever they get it, but it's not as impactful as seeing what you're eating day to day. And then also the device does give you an average HbA1c, and you can make changes, and straight away you start seeing your HbA1c coming down. Because
And I'm sure in
whereas
your lifestyle practice and in mine, when we bring in this continuous glucose monitor, it's like light bulbs going off in people.
absolutely, absolutely, it is really, really incredible. So apart from the HbA1c coming down, the whole average weight loss for each client was 1.7 kilograms, and that is including those who gained weight. Again, for that cohort, we had about 52 patients complete results. So that was incredible. So the average dropped from 82.3 to 80.5 for the whole group.
Mhm.
And then also we saw in 65 patients an improvement in blood pressure. So it dropped from the average dropped from 131 over 81 to 123 over 76. And again,
Wow.
yes, and again, and again, that included those whose blood pressure worsened. So that is really,
This
really impactful.
and how many people's blood pressure do you think worsened? You may not
So
have
I
that
do
data
have
to
that
hand.
information. So
Okay.
36 improved, 17 stayed the same, and 12 patients' blood pressure
Okay.
was
So
worse.
from a public health perspective, this has actually improved things. But I think just to be mindful of blood pressure, this is an amazing result. But we have to be mindful that to get more accurate results in the future, getting an average blood pressure over, say, 7 to 10 days might be a more accurate way of measuring this.
Absolutely.
Um,
Yeah. Yeah.
because obviously, everyone knows, you check your blood pressure a few times, it's going up and down.
Mhm, mhm.
This is so this is so amazing that I did a high intensity intervention in the NHS and I've written up the data. And I was so proud of my results because, in effect, they were better than anything else out there. But I did go high intensity with them, and I got an average drop of 9.54.
Oh,
And you've still done better than that.
mhm.
But I was high intensity, high intervention, and we didn't use continuous glucose monitors.
Yeah.
And you've just shown that by empowering patients, you can give amazing results.
Yeah, absolutely. And it was very, very light touch. We gave them a contact email to contact us if they had any issues with their diets or what have you. Nobody got in touch. Nobody got in touch. They
Wow.
just got on with it.
Okay, so weight fell 1.7 kilos over 2 to 3 months.
Hmm.
I remember sustainable weight loss, so we're looking at a short period of
Yeah,
time.
yeah,
Hopefully that would continue. Blood pressure fell overall from looking at all the metrics, all the population of the study together, and then the A1C fell by a whopping 9.8
yeah,
on average.
yeah.
So really big results. For me, part of this is the qualitative data.
Hmm.
So qualitative, for people not knowing, it's the stuff that's not easily measured.
Hmm.
And I would love to know a bit more about the qualitative impact.
So yeah, so we did do patient questionnaires so that they could feedback, and they did say we asked them what was the most impactful intervention, and like most of them felt, I think 98% said that it was the use of the device. We only had 38 people respond, as you know, with these things, but it
Mhm.
was really, really positive. They felt, some of them felt that the food swaps were useful. We gave them an ebook, and we also gave them an app to use. So they had options of what to use. They also, what we found was, they also increased their activity. And that's really interesting because a few patients also gained weight, yet their HbA1cs dropped, which is incredible, but we didn't measure
Mhm.
waist circumference. And that's one of the things that the
Mhm.
GPs fed back to us, that they felt in the future we should include that because some became more active and they gained muscle, so therefore they gained weight, yet their HbA1cs improved. So it goes to show that it's not all about weight loss, but it is about,
Exactly.
yeah, the lifestyle. Some of them were just more motivated to become more active.
Absolutely. And there's been lots in the headlines in the last few weeks around BMI and why we should potentially not be using the BMI anymore. And I would say that BMI is not your answer, but perhaps we can't get rid of it. And BMI and weight linked together, but it's a risk factor rather than it being
Yeah,
the absolute problem.
yeah, absolutely.
Because weight doesn't tell us about your metabolic health.
No,
It just tells us
yeah,
about how heavy you are,
yeah,
which could mean anything.
yeah, that's right. That's right. So,
So yeah, that's really fascinating. I really find that the qualitative stuff, as I go through my career, becomes more and more important because we are humans and we're not robots.
absolutely.
So we don't just operate as interventions in and out.
Mhm.
In fact, the way we feel will impact what we do in the future, and the way we interact even with healthcare services changes because of our perceptions and what we feel. And that's the human element to to providing
Yeah,
healthcare.
yeah, yeah.
So you got this amazing study. What happened? And just to balance it out, really, for people, not everything in the study is perfect,
No.
because, for example, um, to know more about the qualitative data,
Mhm.
you may have had the people who are feeling more positive may have been more inclined to provide feedback.
Yes, yes.
So there is the entirely but unlikely possibility that 70 people or 60 people who didn't reply were extremely unhappy
Mhm.
and hated it. But of course, that's probably not true. But it's just for people to know that sometimes data can be skewed a little bit.
Yeah.
But overall, this is super super positive.
Mhm.
So what's happened after that? So this was, and just so people know, this study was done in North Central London, in your position as diabetes lead.
Yeah, that was
So
last
this,
year, and we completed it last year, March.
okay.
Yeah. Mhm.
So how are you running this out to the rest of the NHS?
So I did do a lot of publicity. I took it to conferences. I shared it with the organisation as well. I did put it forward for an HSJ award, so that's the Health Services Journal Award, and I was a finalist. I didn't win the award, but it was
Mhm.
recognised as really good work. And also, since I've left the organisation, they've put together a lifestyle team that are looking at
Mm,
lifestyle. So I'm hoping that
that's fantastic.
when they review how they educate patients with diabetes, that they will be incorporating this into the
Okay.
program. But one of the problems with the NHS is if it's not approved by what we call NICE, which is a body that approves technologies and makes recommendations for patients' healthcare, it's very difficult to get funding and support. And a lot of people, and because the organizations are already struggling with their budget, they find it difficult to find the money to invest in this technology.
Having discussed with some business heads in the grants world, they have told me in the 30 to 40 years of their own careers, this is the worst it's ever been in terms of accessing funding for new innovation and technology.
Yeah.
And it feels really sad to hear that. And I guess when my career spanned 15 years, it doesn't register to what it used to be like before. But of course, it does sound like this is a tough environment to be bringing things in. But you've potentially shown some amazing cost savings here.
Yeah.
And you and I have discussed a lot about how to move this forward over the last few months, and you've really tried to spearhead this. But you've entered a few difficulties, which could be interesting for other people to learn from. So, what would you say were the big barriers that maybe you still need to overcome, or in hindsight could have done differently?
So I think the barriers for me is just like it needs to be published, and we haven't published that, and that's very difficult because I think it was a very small scale pilot, and we really need to roll it out much wider to see how that works on a wider population. I think we also need to monitor the patients for longer, but I did leave the organization, so the work has stopped. And I think that's really,
Mm,
really important. But I
mm,
do feel that avoiding initiation of medication in that 67% of patients is really powerful, even if it's for 3 months,
mm,
because
mm.
these medications are very expensive. So
Yeah.
if it's for 6 months, it's even better. So
Mm,
avoiding initiation, really important. We really do need to look at it, um, because what we did was cost avoidance. Some people don't really value it, but we have to think differently, because if we could get the incidence of diabetes is just going up,
mm.
unabated. If we could
Yeah.
prevent people from getting diabetes even for 1 year, that's going to be a
Mm.
huge savings to the NHS.
And for me, it's more than just preventing people getting diabetes. It's helping people who have established diabetes to manage it so they don't develop complications, because diabetes itself doesn't mean a life sentence of misery. It actually, there is still opportunity to get it controlled with medicines, without medicines,
Yeah.
but there are opportunities to get it controlled. Ultimately, the person who's the pilot needs to have as much information as possible. And if you, the pilot, are trying to help manage your own body, and people are trying to do the best possible, getting them more information as possible for probably quite a £50 may sound expensive for some people, but when you think about the cost of healthcare and the delivery of it and appointments and the rest of it, this is really minimal cost
Yeah.
in terms of the alternative,
Yeah.
especially when
Absolutely.
it comes to the complications. I just want to just make sure we have a bit of time. I think we could keep talking about continuous glucose monitors. There's so much to do, but I want to make sure we have time to talk about what has happened now with your career, because you have. Is it? Have you've retired from the NHS?
Yes, I have. Yes, after
Okay.
about 32 years as a.
Okay, I have to say you don't look old enough to retire from the NHS.
Well, thank
Am I old
you.
enough to retire from the NHS?
I know it's I follow the lifestyle myself, so I practice what I
Excellent.
preach, and I'm very happy. I'm not on any medication, so
Okay.
I'm very blessed that way. And
Okay.
I just like talking about it so much, and
Okay.
everybody who knows me knows about this lifestyle. Those who are
Yeah.
not practicing it have chosen not to practice it, and those who do
Yeah.
know me are practicing and want to, they are practicing it as well. So
Yeah.
I turned this into a little business because it does take time to support people. And I
Yeah.
run coaching groups on how to
Mm,
change your lifestyle, improve your health, reduce your reliance on medication,
mm.
and it's going really, really well. It's going really well
This
for
is
those
amazing.
who want to make those changes. So absolutely, I've supported people. The easy bits are blood pressure, diabetes, kidney disease, and
Mm,
obesity. Those are very easy. But whilst I'm talking to clients, I've met people with more complicated systems, and it seems to work for them as well. Like
yeah.
recently, with it at the end of last year, I had
Mm,
supported someone to reduce his PSA, his prostate antigen specific antigen
mm,
level down from 13.2 to about 10 point something, and it's on a
mm.
downward trajectory just in over
Wow.
4 months. It
What did you? Was that because of the same protocols that you implemented with
Yes, so
type 2 diabetes and CGMs?
absolutely. Just trying to reduce the blood sugar spikes to eat within a stable blood sugar level, and it's just started coming down. That was just amazing.
Mm.
I've
I
helped.
don't have data to hand,
To,
but I think it's Professor somebody in Cambridge
Mhm.
who has done a regression analysis on the amount of sugar people consume and the risk of prostate cancer.
Yeah, 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 absolutely. Apparently,
Professor
it's
somebody.
only men and dogs who are fed by humans who develop it. So it must.
Oh gosh,
Yeah.
okay. We'll definitely need to check that, because I can't absolutely vouch for that information. But it's a really interesting insight there. So if anyone is taking that soundbite, absolutely, I think it's something you should be aware of, and look it up, because it is interesting how certain things are growing quickly.
Yeah,
Though,
yeah.
and and sugar is more than diabetes. I think people are starting to realize that.
Absolutely, absolutely.
Yeah.
So other conditions that I have supported, Sjogren's, someone with Sjogren's,
Wow. Wow.
wanted to lose a bit of weight, wanted to be healthy, and has now come off all her medication by just being
Mm,
consistent. Not
mm,
really tightly controlled, but she's not fully healed, but she's so much better than where she used to be. Someone else who
mm.
had hydronitis supraretiva, so
Yeah.
that
Yeah.
helped as well reduce.
That's the one where people get really bad
Yeah,
boils in their
yeah, boils
armpits
in
and
their
things like that. It's really,
armpits,
really
and
awful and
yeah,
painful. Yeah.
just epilepsy, and even
Wow.
someone who I just supported them because I know how the NHS works. I supported them in getting their a tumor diagnosed because they had low phosphate, and we had to look into what was causing it.
Mm,
And I said to her, why don't you suggest this to your team? And then they did a
mm.
scan, and they found a tumor secreting this hormone
Wow.
FGF23. and that was making her bones soft
I'm
and
not familiar with
brittle.
that.
Yeah, absolutely. I wasn't either. I didn't
Wow.
know. I said, maybe you have a problem with this hormone. And then when they did the scan, they found the
Okay.
tumor, took it out, and now her bones are back to normal. So I do advocacy and all sorts of things and just support people to live
It's huge.
healthier.
It's these unintended consequences of supporting people with their lifestyles. I find
Yeah.
it, I mean, this may sound far too, and it is far too simple to say this, but one device combined with your knowledge is really having a massive impact. I know it's not the CGMs just doing this, but
No,
it then
no.
stems out to so many other things.
Yes, I just want to also say that just wearing a CGM and not having the knowledge behind it and how to use it is not helpful. So some people wear it and
Agreed.
they
Yeah,
don't know
good,
what they're
good.
doing with it, and they just don't know what to do. So
I find
that's
for
where
some people it does worsen their kind of feelings around their blood glucose because they're like, now I don't feel
absolutely
like I can eat anything because all I
it
see
can
is these
cause.
continual rises.
Yes, it can cause anxieties. We had one of
Mm,
the patients on the pilot who didn't want to wear it anymore because she said it was just making her anxious. So,
okay.
yeah,
So with anything, we've got to be careful that there are some potential drawbacks.
yes, absolutely.
And so for each person, it's going to be different. There's going to be a difference in whether this is going to be as helpful now and into the future if they want to use them again.
Yes, yes, that's true.
Um, with these, oh gosh, it's gone from me. I was just about to ask you something. The best question. So, I'm going to ask you about the prescribing. So,
Mhm.
you're, would you say you're prescribing less and less now?
Well, so for me, the people I work with tend to come off their medication, tend to reduce their medication, and I'm not supporting any GPs in prescribing at the moment, but the work that I do tends to get people off medication, and it also stabilizes their conditions and prevents it from getting worse. Like, for instance, with my own mother who had angina, heart failure, diabetes, blood pressure. When she was 79, she's now 83. She also had chronic kidney disease. And when I started working with her when she was 79, when she was ready to work with me, because it took a long time to get her to where she needed to be to agree to work with me, 6 months later, she came off 4 medications. And
Wow.
yes, and recently she's moved to Ghana, and her EGFR, that's her kidney function, is at 95 at 83 years old.
For people to know, more than 90 is seen as normal even when you're 21. So if you have an EGFR of 95
Yeah,
in your 80s, it's just like phenomenal.
yeah,
It's really amazing because unfortunately I see so much more often than it's perhaps discussed. The impact of diabetes and kidney disease is it's really ravaging so many people's lives. Um,
absolutely.
we have to tie off in a moment, but I have to say that this has been really amazing. Just thinking about a real detailed discussion about glucose monitors without trying to tell people this is a problem or that's a major issue. This is more of a discussion about how they can really help. But you mentioned about the potential drawbacks, and it goes into realizing that the glucose monitor itself doesn't fix the issue.
Yeah,
In fact, it lends itself into giving you more understanding and insight. And when you combine the data with health coaching support or support with a practitioner who can read these for you, then you start to get that insight, and then that then leads to change. And this is a lot around the psychology because people are motivated, but sometimes they're motivated and then they do the wrong things.
yeah,
And they may be doing lots of right things, but some of the wrong things might be involved in that. By doing this, what you're doing is you're saying, these are the things that are going to have the biggest impact. So let's just with the motivation that we've got, let's do the behavior change in these certain areas.
yeah.
So I think it can be really impactful. So I'd love to know from you a little insight, maybe something that people who are watching, the people who are watching this are going to be a mixture of healthcare professionals and patients. So maybe we can have a couple of messages or as many messages as you like. What insights would you like to give the audience at the end of this discussion?
Okay, so when I was growing up, I went to school up to about 9 years in the UK, and then I did my secondary education in Ghana, and then I came back and went to university here. But whilst I was in Ghana, I saw all my relatives developing high blood pressure, diabetes, strokes, and all those problems, obesity. And I had assumed that it would happen to me because it happened to everybody else. I came to the UK, I did my pharmacy degree, and I learned that diabetes was a progressive disease that will never, what do you call it, you could, once you get it, it will just get worse and you die from the complications. So even as I was working, I believed that until, and I thought, well, maybe I could outsmart it by being healthy, running 10K a week, going to the gym, doing strength and training exercises. And however, when I got to my 50s, I started becoming pre diabetic. My blood pressure was creeping up, and my GP wanted to prescribe medication for me. And I was thinking, well, I'm doing all this work. Why is it happening to me? And I said to my GP, let's put a pause on that and I will go and do my own research. And I found a community of people who that had happened to them, but they were able to turn it around. So the message that I want to share with everybody is no, it's not necessarily that you would go down that path. We genetics exist, but lifestyle, as a loaded gun, lifestyle pulls the trigger. And you shouldn't
Mm.
let these long term conditions define you. There's a way out. They can be put into remission. You just need to know the right thing to do to turn it around. So, and I know long-term conditions causes a lot of depression, and it
Mm.
makes people's world smaller because they can't go out anymore, and
Mm.
they feel that that's the end of the world, but it is not. You can live a healthy life well into your 80s and your 90s as long as you know how to manage it. And it's all about you. Don't wait for someone to come, like your GP to say, now you do this, now you do that. You need to start the work now for a better future.
Thank you. That's really powerful and really well put.
Thank you.
Um, I think we should end on that actually.
All right.
So, look, if you want to stay in touch with both of us, you can find us. Efa, you're available on LinkedIn as well. People can
Yes,
find you on
I'm
LinkedIn.
on LinkedIn.
Okay, so
I have a
is
website.
LinkedIn your main jam and website? So let's go through them. So LinkedIn, Efa Mortty.
Yes, absolutely. My website is n number 4 ws.co.uk. So that's nutrition for wellness support.co.uk, n number 4. And then also I'm on Instagram, so it's n number 4 wellness with 3 s's. So you can find me on Instagram as well.
Thank you very much, Efa. It's been great having you on today, and
Thank
maybe we'll have to do another deep dive on glucose monitors and more about the support that you're providing with clients in the
you.
future.
Okay, thank
Thank you
you.
very much.
Yeah, right. Okay.